Hello, welcome back to What Now? On the Threshold of Life, Death, and Grief. I'm Julie Brown, and I'm here with my friends and colleagues.
David Kennedy.
And Red Keating.
And today we have a very special guest, and we're really delighted to dive into this conversation, Dr. Naheed Dosani. I'm going to just give his official biography, and then we'll dive into some more storytelling and sharing. So as a palliative care physician and health justice activist, Dr. Naheed Dosani is dedicated to advancing equitable access to healthcare for people experiencing structural vulnerabilities like poverty and homelessness. These efforts include founding the Palliative Education and Care for the Homeless PEACH program at the Inner City Health Associates, serving as the medical director of Kensington Hospice in downtown Toronto, a health equity expert advisor at the Canadian Partnership Against Cancer, and as a palliative care physician at St. Michael's Hospital at Unity Health Toronto. Dr. Dosani shares his passion for palliative care and health equity with learners as an assistant professor with the Department of Family and Community Medicine at the University of Toronto. His research interests include improving care models for people experiencing structural vulnerabilities and access to palliative care for culturally diverse communities. He has received many prestigious honors for his trailblazing work. These awards include the Meritorious Service Cross for Humanitarianism from Canada's Governor General in 2018, a humanitarian award from the Canadian Society of Palliative Care Physicians in May 2019, and the Early Career Leader Award from the Canadian Medical Association in 2020. Most recently, he received an honorary degree, Doctor of Laws, from Ontario Tech University in 2022. Wow. Thank you and welcome, Naheed. Thank you so much for being here with us.
Thank you so much for having me on. I'm really looking forward to the conversation.
Well, and I too, I just want to jump in and say how pleased we are that you've agreed to do this, because I think the conversation that we are going to engage with you today is a topic that's universal. Certainly, it's not limited to the city of Toronto, and I think we are just so privileged to have someone like you who has developed a response to a very real problem, and we're anxious to share that. And thank you for being here. I wonder, Naheed, if you just kind of introduce your own personal self to us a little bit of your background. What got you into medicine in the first place? What was your thinking in that one?
Yeah, absolutely. It's really exciting to be here, and I think how this all started is a really good place to start. Yeah, so I was born and raised in Scarborough, Ontario, as the son of two parents who came to Canada as refugees in the 1970s from a war-torn country. They fled war and persecution from Uganda and came to Canada with very little. Growing up in a home like that was different. It was difficult at times, and it really taught me a lot about the meaning of what community meant as it pertains to our health. And also it was a quick class on the importance of the social determinants of health. I think growing up, I always saw that there would be different ways that I could create change through different platforms or different ways of learning. At one point, I wanted to be a journalist and saw that as my route. And another route, it was engineering. But as I started to proceed through my studies, I started to learn more about the ways that health practitioners were using healthcare as a platform for social change in their communities and around the world. I read, books by famous Canadian clinicians like Dr. Samantha Nutt, Dr. Richard Heinzel, James Orbinski, for example, who have done incredible work with organizations like War Child Canada, Dignitas, and Médecins Sans Frontières, for example. And so I started to really see that this thing called healthcare could not just provide great medical care for people in our communities, but could actually inspire a better world for all of us. And I think that's how the story really began, and that's what led me to pursue medicine. I pursued studies at McMaster University, and then later completed my residency programs at the University of Toronto after that.
And how did that sort of journey lead to palliative medicine then?
Yeah, I'm going to be really honest. Going into medical training and early on in my training, I didn't really even understand what palliative care was. I think we do better at teaching about that now, and that's kind of across the board. No matter what school you're looking at across Canada. And so it was really when I was a first-year resident doctor at the University of Toronto, while I was providing primary care at a local men's shelter, when I was asked to see a gentleman who was in crisis. He was shaking, he was writhing, he was curled into a ball, and as I examined his mouth, I could see what was causing him so much distress. He had a tumor that had started at the base of his tongue and had spread throughout his head and neck. His name was Terry. He was a man who had been on the streets for over 2 decades. He was a person who used drugs. He had a mental illness, schizophrenia, and was actually diagnosed with his cancer 1 year before at a local cancer center. And as time went on, what actually happened was, because of his mental illness, he wasn't able to follow up for care. And so the tumor grew. So he started to experience pain. And so he did what any one of us would do. He went hospital to hospital, ER to ER, walk-in clinic to walk-in clinic, seeking the kind of pain control that any person should have access to. For whatever reason, Terry was denied access to medicines that would treat his pain and quality of life. You can imagine that might have been stigma, maybe misunderstandings, maybe miscommunication. Anyways, he found himself in our care. And I remember, building a rapport with him, and he promised to start some pain meds the next day. I got to work early the next day, but I couldn't find him anywhere. And I had found from one of his friends in the shelter that he had actually died overnight. His body was found by a commuter on her way to work. It was too little too late. He had overdosed on a combination of alcohol and street drugs. So, for me, it was a very traumatic event, how someone could fall through the cracks again and again and again. And then again, at the end of life, it was very frustrating in a world-class city like Toronto, where we have world-class healthcare, primary care, cancer care, and even palliative care. And this, for me, really opened the doors to what palliative care was, but more importantly, also showcased for me who wasn't accessing palliative care. I later came to learn, when I pursued my palliative medicine residency, that it wasn't just Terry. There were many, many people like Terry, people who experience homelessness and poverty, but actually inequitable access to palliative care is seen across our system. We see it through the lens of systemic racism. We see it along income gradients as well. We see it people who experience mental illness, refugees, new Canadians and immigrants, for example. And so there are many kind of health disparities we see when it comes to palliative care. And that kind of, I guess, led me to this conversation today.
You've referenced before in your TED Talk and in other interviews that homelessness is a life-limiting illness or disease. Can you speak to that?
Yeah, I think at the outset, when people think about statistics related to, illnesses, we often think of medical diagnoses that affect biology or genetics, and so you have to kind of walk with me here. So, I think most people know that the vast majority of what makes us sick is actually the social determinants of health, how we live, learn, work, and play. And it's estimated that over 60% of what makes us sick is actually social. But when someone doesn't have a home, or they live in poverty, or both, essentially that means that people can become very sick. And what we see with the health outcomes of people who experience homelessness in Canada is that that's the case. People who are unhoused in Canada are 28 times more likely to have hepatitis C, 5 times more likely to have heart disease, 4 times more likely to have cancer. And average life expectancies for unhoused people in Canada range from 34 to 47 years old. Now, when you look at housed Canadians, people who have homes in Canada live an average of 77 to 82 years. And so homelessness, when you look at the strength of this data that is obviously tied to the social determinants of health, it's obvious that homelessness is a terminal diagnosis. It's not how we often think, but it's a terminal diagnosis of the social determinants of health. And if you agree with me that the vast majority of what makes us sick is social, why are we surprised that people who don't have homes are getting this sick and are dying this soon in our communities? And that's why it was so important for us to respond. And that's why we started the PEACH program in Toronto. And that's been our response for the last 9 years to this issue here in Toronto.
Was the PEACH program a challenge to get going? Did you meet resistance all along the way?
It's a really great question. I think, at the outset, I want to say that there were a lot of people who were in great support of the concept. When I really envisioned the Peach program with community members while I was actually still in training. It's not usually when people are coming up with innovations. It was like we literally started the Peach program the day I graduated from my residency program. A nurse named Amr Ahmed, my colleague, and I co-founded this program at the Inner City Health Associates in Toronto. And we literally started this program out the back of my Honda Civic, driving around 1 to 2 days a week. And, I kept that Civic for a very long time. And, fast forward 9 years later, the Peach program functions as a 24/7 model of care. We have 7 palliative care physicians on the team, a social worker, health navigator, a nurse coordinator, a home care coordinator, and an interprofessional roster of home care professionals that care for between 110 and 120 clients on caseload at any given time. And the program has been replicated in cities across Canada and around the world as well. And so, it's interesting to look back at this question and reflect on that. And I think at the outset, it's important to say that while community members who worked in the homelessness sector did recognize that this was important, there were in the healthcare sector, it was very difficult to actually get started. I had actually pitched the program to several organizations. I was laughed out of many rooms, told I was too young, told that this was not an issue, or the more common response was, we already do this. And it was very clear and apparent from the statistics and my training and my experiences and the experiences of people who live experiences that this was actually not the case. And so there was that piece. But, at ICHA, the Inner City Health Associates, I found a compassionate community of health workers who were really looking to do something different and innovative. And, they gave us a chance. And after 1 year, we showed that this program was successful. We had 42 intense cases that year, and we showed that 64% of the time, our patients never went to the hospital or ER. 80% of the time they died where they wanted to, and 83% of the time they were reconnected to family or friends if they wanted to. And that, to us, was a very powerful, speaking along different metrics related to healthcare utilization, a psychosocial metric, and even like a goals of care preference metric, right? And I think those statistics were really important to really showcase the value of the program. And here we are 9 years later, right?
Wow, that must have taken an incredible amount of energy and work and organization. Because is it all like a mobile unit that moves about the city? Like you did it at the back of your Honda, so I'm thinking, are all of the folks that you've mentioned there all sort of on the street with the people they're working with?
Yeah, for sure. So when we think about healthcare, we often think of a hospital or a health facility or a clinic, and those are really important models of healthcare. When we talk about what the Peach program does, we're talking about a very true definition of outreach. We absolutely are mobile, so no 2 days can really look the same. Our clinicians are driving around the streets, going to parks, going to shelters, going to respites, drop-ins, meeting people under bridges, so no person falls through the cracks. In some cases, groups of clinicians are clustering to see a client if there's a need for joint visits. Sometimes we stagger our visits so that we can get more contact with people. And what's really interesting is we're not working in isolation. The Peach program would never succeed if we just did this in a silo. What we're doing is connecting, partnering, and collaborating with people who already do this work really well. Community case managers who support harm reduction, mental health counselors, for example, other social care institutions, and like shelters, respites, and drop-ins, and working with them and their teams to connect with clients. And at the beginning, it was a lot about teaching what the palliative approach can look like, when to initiate it, when to initiate referrals, for example. And as the years have gone on, many of these sites have sophisticated to the point where they initiate a palliative care approach on their own. Many of these shelters, respites, and drop-ins are now supporting advanced care planning, and we come in at a juncture at a time when things get a little bit more complicated and there's extra need for support and help. So we've even seen the nature of the work evolve as well with our partners.
Could you help maybe paint a picture as an example of one of those around how that might be happening, delivering good palliative care in a shelter?
Yeah, for sure. There's many vignettes to choose from, but I will, talk about a gentleman who we actually had featured in a radio documentary a few years ago on CBC. His name was Archie, and he was a gentleman who had a very tough life. He actually was an engineer. He had a home, and due to an unfortunate sequence of events, found himself on the streets. And then he was diagnosed after experiencing some abdominal pain and vomiting with terminal gallbladder cancer, basically. And he found himself in this shelter. And as his care needs started to evolve and increase, the shelter found it increasingly difficult to have him there. Not that they didn't want him there, but just that the level of care that they could support wasn't feasible. And so they asked the Peach team to come and get involved. And we met him where he was at, where he wanted to be. And given his life circumstances, he considered that shelter to be home, and he wanted to be there. We supported medical care, we supported symptom management, but that's just a small part of it. We also met him to connect with him around his income and working to optimize his income through social assistance. We then also supported him through his psychosocial needs. He felt very isolated. He felt very lost in the system. He felt somewhat betrayed by a system that was now forcing him to essentially go to the hospital because he wasn't getting the care he needed at the shelter. Through home and community care and that bridge, we were able to support him with bathing, showering, dressing, some clothes, medication management, wound care management right there in that setting. And all of a sudden he was able to stay where he wanted to stay. At the same time, we provided education for shelter staff to be able to support them on what a palliative approach to care is, can and should or could look like, to support them, the workers through grief, which I'd love to talk more about later. And really support them through the natural trajectory of this illness so that they could then support him as well. Ultimately, Archie died where he wanted to, in his home setting. It's a tragic, story, of course. It's sad that he died, but his last wish was to be there at what he considered home. And I think this really is an example. And, one of the things I'll never forget about him is he loved to sit in Allen Gardens, which is this large park in Toronto. It's pretty renowned. And he loved to do the daily crossword. And with his consent, we would even do our medical visits in the park to see him so he could spend the time that he had left doing the things that he loved. And it's a real reminder that we must always acknowledge the full dignity of each person beyond the stigma of their marginalization. I'll never forget Archie, because of that.
Wow, that's such a powerful story, and it's so true, Naheed. And I think what we miss is that key piece around this is home for them. And, we look at that, or others look at that and say, why don't they just go to the hospital? Why don't they even go to a hospice? But even hospices can be uncomfortable because it's not their environment. And so, there's that piece where we expect that home opportunity for people, and yet we don't recognize what that means for people at all levels, that they have the right and the dignity to make that choice about their own dying.
Absolutely. I think what we do sometimes in our work, and I think it's well-intentioned, to be fair, is we project our ideals on the people we're caring for. And if we're really person-centered, we wouldn't do that, right? We would really listen to people's voices. And yeah, many folks that we care for do consider, their shelter, respite, drop-in, their social housing unit, whatever it might be, their home, even though many of us would not. Now, I also want to say that there are some other folks who don't consider that home and would jump at the opportunity to be in a traditional mainstream hospice. And we've seen that too. But then it's also about how we approach folks. And we talk a lot at the Peach program about trauma-informed care. And I know you do too. And so I think we should probably talk about it, and to say that that's an important aspect of how we meet people where they are at. My hope is that in the future, clinicians who work in palliative care, will be talking about trauma-informed care left, right, and center. It will be such a common thing that we talk about, because we know this population has often experienced trauma, often at the hands of healthcare. And particularly at the end of life, it's such a great opportunity to heal people, even though they're very sick. And I think the way we do that is through trauma-informed care.
Yeah, so let's dive in on that. What does that mean for you? And let's talk about it maybe even really pragmatically. Like, what does that mean in action, trauma-informed care?
Yeah, I mean, I think just for listeners who are new to the concept, I think trauma-informed care is an approach to care that recognizes that the people you are trying to care for may have experienced trauma at some point, and may have experienced trauma in healthcare, at the hands of healthcare. You don't need to know about a person's extent of trauma to be trauma informed. It's everything from how we treat people at the one-on-one kind of level. A lot of clinicians focus on this part, and that's because they want to be trauma informed. And so it's things like learning how to pronounce someone's name, learning someone's preferred pronouns, sitting at eye level, thinking about the entire trajectory through a healthcare institution, and being aware of the spaces and places that might incite trauma for people. Some people feel very uncomfortable in closed spaces. Some people feel uncomfortable being alone in new places. And so that's why we offer opportunities, options. That's why we offer accompaniment to appointments through the PEACH program, for example. But broadening out, at the MISO level, you could really think about, trauma-informed care is informed strategies to deliver care. So many have told me over the years that the PEACH program is a trauma-informed approach to palliative care delivery in our communities. And then at the macro level, I think we can be very trauma-informed in our approaches to care through policy. So, I hope that one day in the future that palliative care bodies across Canada, endorse and support the concept of harm reduction, something they don't currently do for people who use drugs. That would be very trauma-informed. When all the clinicians and the teams that do this work across Canada join up and write a letter and say, write to the Prime Minister and say, we need to end homelessness from the perspective of palliative care clinicians who do this work. That's trauma-informed, advocacy and policy, right? And so, while we often talk about that one-on-one patient interaction, that's obviously super important to this. We can really talk about our approaches from a program and policy perspective as well. And so, I think trauma-informed care is really front and center when we talk about these kind of topics.
And I'm thinking, I'm going back to your example of Archie meeting him in the park while he was doing his crossword puzzle is such a really tangible example of trauma-informed care. That park, because trauma leaves us feeling psychologically and physically unsafe, right?
Yeah.
And so if that park is a place that was soothing or comfortable, it probably felt safer, maybe not, lots of people with trauma never feel fully safe, but maybe it felt safer. And so then we meet him there. And
Totally.
I think that's just a really, and I love how you took us there from trauma-informed care in human to human, but then through our systems as well.
No, thank you. And I think the opposite can be true when we don't offer trauma-informed care. This is not fluffy, fuzzy, wuzzy stuff. This leads to poor health outcomes for people. And I think of one of the clients that we cared for named Pandora, who was a young woman who was born and raised in Alberta, and due to physical and sexual violence, fled her home community to move to Toronto, where she was living on the streets and unfortunately fell into a life of drugs. She developed a complication in her heart called infective endocarditis, and she ended up in a hospital where she was supposed to receive potentially life-extending surgery of a heart valve replacement, and unfortunately was denied access to this surgery because she was a person who used drugs, even though there's no research evidence to show that people who use drugs do worse with this procedure. That was that was trauma on trauma from her. So she left the hospital, and so we met her on the street where she was short of breath, without medicines to treat her pain, without a roof over her head, and worked with her to connect with her. And actually, there was a documentary we were filming at the time, and you plan these things, and we were starting to tell her story because we thought it was a very powerful story. And as much as we built a rapport and relationship with her, she was hurt. Her heart was broken, and unfortunately, during the filming, Pandora actually died due to an opiate overdose death. And the documentary shifted, obviously, to show the ripple effect on our community, but also on our healthcare community and what that can do. So trauma-informed care can really help a lot of people, and not offering trauma-informed care can reinforce concepts of stigma that can lead to really bad outcomes for people. And these are real hard, actual healthcare outcomes we're talking about.
In the trauma uninformed world, we would probably call some of those clients non-compliant.
Yeah.
They're not following how we've set it out for people to get access, right? And I hear that a lot when people are experiencing their grief. and well-meaning friends trying to be supportive come along and say you shouldn't do that or you should do this. Like there's one way to grieve and you're not grieving correctly, right? And so that judgment gets made on how people grieve. And you said you wanted to talk a little bit about grief, and I wanted to make sure that we got back to that because that was something that you wanted to speak to. But you see that sense of people making the judgments about how people grieve, and maybe trauma-informed grief would not make those judgments, right? Would let the person be where they are.
Such a good point, Red. And as I think about grief, I think that I know that we have a lot of work to do, and I know you three are doing this kind of work to really improve our systems to support people through their grief. But we also have to really be honest about the kinds of support systems we've created for grief. There are a lot of support systems for grief for people who are often considered traditional family, like blood relatives. And in our work with the Peach program, a lot of the time the caregivers are not actually traditional blood family. They're street family. They're street brothers, street sisters. They're friends who live in a shelter together. They're folks who are trying to survive and thrive on the street. And these caregiving relationships are actually quite strong. And we're actually doing some research right now to learn about the resilience that exists within these relationships because it hasn't been described so much. And so when someone dies, this is how our system is. Someone will end up in a hospital that we've cared for, and then this informal caregiver, a street brother, will try to go visit his street brother, and they won't let him in the room because he's not listed as next of kin. That can further exacerbate, worsen trauma and complicate the grief that we already feel, that he already feels. And that actually, these kinds of things happen all the time. Just pivoting a bit, I want to really give a shout out to the incredible social care workers that do this work day in and day out, whether they call it palliative care or not, in the homelessness sector, who are supporting a lot of critically serious ill people in community who often don't have the resources to do that. We at Peach get to meet some of those folks, but we know there's many, many more out there. And so since 2015, the Peach program has been holding grief circles for inner city workers. And grief circles, grief circles are this really what we think is an important intervention to address the grief that many inner city workers are facing. There's a homelessness crisis, an opioid overdose death crisis. We just had the COVID-19 pandemic. There's a lot of death, a lot of sadness, a lot of loss, a lot of trauma people are experiencing. And so when a Peach client dies, we descend on a site and we light a candle, hold a minute of silence, and we cry together. And then we laugh together. And then we remember what it was like to care for the person. We reflect on what it was like to care for them. And then we think about ways that we might be able to renew and reinvest in each other. We call it the 4 R's. And then we hold another minute of silence. We put that candle out, and then the grief circle is over. And creating these structured spaces for grieving has been very powerful to help a lot of people heal. I'm not saying it's solving all our problems, but why is that not a common intervention? Why don't we do more of this, right? I don't know, you guys tell me, but
No, that's the question we all ask, and it's not rocket science. But it's that disenfranchised grief piece that doesn't get recognized, and especially as you just expressed, caregivers are often not blood relatives, and yet they're disenfranchised in their ability to acknowledge the reality of that grief, both from other people acknowledging it in them and even themselves, giving themselves permission to say, yes, this is grief. This is real grief that I need to pay attention to. And I love that circle idea. I think that you're right. There's no one thing that solves this, but giving opportunity of expression is some of the most wonderful gifts that we can give. And I can only imagine what that circle does and how the power of those circles are. So thank you for paying attention to that grief piece. Let me turn it just a bit to you. What do you do to deal with all of this grief, and this challenge? It has to impact you.
Yeah, I mean, I think if you look at it through one angle, it is It is true, right? I mean, you're talking about palliative care for people who are arguably our community's most marginalized and structurally vulnerable people. And so when I go to a party and I tell people what I do, I often get I often get this response, "Oh, that must be so depressing. That must be so sad." And I actually, really reflect on that and say, well, you know what's sad and depressing? Not doing anything about it.
Right.
Not actually being out here and responding and creating some sort of cogent response to these multiple overlapping crises that are superimposed on each other. And so I think that's one level of it. We've talked a bit about the grief circles and how important that has been. Those have been very important for me. But I think what we talk about at the Peach team and in our work is we generally talk about this concept of creating these antidotes to burnout and moral injury and compassion fatigue. And I think one of those antidotes or responses has been to be advocates, and that's not a small A, like a capital A. And we've talked a bit about sort of my personal advocacy, but actually, many of my colleagues who do this work in health equity and palliative care across Canada are actually the face of many advocacy campaigns, whether it's about raising the rates around social assistance, whether it's about fighting for uninsured healthcare for people, or it's about fighting for housing. On multiple levels, we are advocating, we are on the media, we're using social media, we're writing op-eds, we're constantly having conversations like this one to get it on people's radar and really make change. I can't imagine a world where we go out and work in the system that fails so many people and butt against the system failures every single day and then come back and just like go to bed. We have to do something about it, right? And that is very healing in many ways, and it gives us something to tangibly do with what we're working on. I dream of a day when a Peach program doesn't need to exist because people have homes and healthcare is equitable. And I know we're a long way from that, and so we have a long ways to go. But that's the ethos of it as well. And we found that advocacy has been huge to be able to kind of address some of the moral injury and compassion fatigue we might feel from a day-to-day basis.
And I know you've been speaking of advocacy, I know you've been very involved recently in some events in our provincial government around advocacy work for the uninsured. And I feel like we would be remiss to not just give that a few moments here. Would you like to speak to that?
Yeah, no, I really appreciate that, Julie. Thank you so much for giving me the opportunity to talk about it. I think it's important for folks across Canada to know that in Ontario, the government really actually did the right thing in 2020 by implementing a program that ensured that no person in Ontario would be turned away from healthcare, and that meant a lot to people who are uninsured, people in our communities. These are folks who are living and working in Ontario as residents of Ontario, people who often face significant challenges as humanitarian claimants, undocumented folks, people who experience homelessness, people who are dealing with complex mental illness, for example. And during the pandemic, they had access to physician care and they had access to hospital care, which was really amazing. And with my own eyes, I could see the change. People were getting access to life-saving care. People were getting access to surgeries. People were getting access to cancer care, and it really meant the world. And really, it really created a more equitable plane for people who experience marginalization in this way. And more recently, just a few weeks ago, the Ontario government stated that they would be ending this policy. And it's actually, as of 5 days ago, this policy ended. So, basically overnight, people who are uninsured in Ontario no longer had access to healthcare. And, there's the moral aspect of this, where it's not right to deny people healthcare because healthcare is a human right. But then there's the logic part of it as well. It doesn't really add up, essentially, because what will happen is that people will essentially not get the timely access to healthcare that they need upstream. Their diseases will just evolve and develop and progress, and then they'll just end up in the ER and in hospitals at the end anyway, where we have to pay for it, and there won't be a budget line to pay for it. It's going to come out of the physiotherapy budget or the pharmacy budget, or other budgets that we as people who have OHIP depend on, right, for our healthcare, which will increase wait times. And it's a really inefficient way to deal with the problem because it actually costs more. So it's not just the right thing to do, provide healthcare. healthcare. Sorry, it's not just the right thing let me rephrase. It's not just the right thing to provide healthcare for uninsured people, but it actually is the smart thing to provide healthcare for uninsured people as well. Thanks for giving me the chance to talk about that.
So I know, wow, there's so much for us to keep talking about.
Yeah, I could go for another hour, actually.
Couldn't we? I have a couple things on my mind. Just very quickly, homelessness is so often misunderstood. And before we started recording today, my colleagues and I were talking about how sometimes we distance ourselves from people that are homelessness. We kind of what I call like unreal other them. We forget about their humanity. And homelessness is a very complex thing. And I guess I just wanted to give you a moment, if you have anything to add to help our people who might be listening to this, who just think, well, if you wanted to get a place to live, you could get a place to live. It doesn't need to be like this. What would you like to say to that?
Yeah, I think that you're right. One of the challenges in doing this work is not just the work, like the clinical care of people who experience homelessness. It's battling stigma and public perceptions of people who experience homelessness. And many people, have very negative feelings about people who experience homelessness. And I'm just here to say that those perceptions are wrong. I've never met a person who experiences homelessness who really wanted to actually be in that situation. Typically, people are in that situation due to a weakening or failing social safety net, due to structures that have let people down, and due to a lack of compassion actually in our society. And so what I would say to people also is that, homelessness can happen to anyone. Any one of us are just a few paychecks away from being homeless, a few bad incidents of bad luck from experiencing homelessness. And I've seen people who experience homelessness who had doctorates, who had law degrees, people who were politicians, people who were athletes. Like, it really cuts across the entire intersection of our society. I always say, if the Canadian public was to look in the mirror, what you would see looking back are people who experience homelessness along the same light. There is no, it does not discriminate in that way. And so, it's important to remember that people who experience homelessness are human beings. And we need to do better at seeing this issue not as a issue where we blame individuals, but rather we look at blaming a system that creates situations that people fall into being people who experience homelessness to begin with. And there's so many issues to talk about, right? We've talked about some of them here: access to healthcare, access to eye care, pharmacare, dental care. We could also talk about social assistance rates that are so low in this country that many people on social assistance, people with disabilities, are actually living in poverty, even though they're on social assistance, which is like legislated poverty, essentially. We talk a lot, I think, nowadays about affordability and the housing crisis and the lack of affordable housing stock in Canada, which is obviously playing a role into why we're seeing so many people experience homelessness. And food insecurity is another one that's also been talked about a lot in the media, and the high cost of food. And so, when you talk about all these factors, it creates a perfect storm for someone to really fall through the cracks again and again and again and then again. And so, I hope that, just this conversation has brought to life what homelessness is and isn't. And I hope we can continue to destigmatize the experiences of unhoused people on the street, so we can start to get to some real tangible policy solutions. Because ultimately, the way we're going to end homelessness is through policy and reform, and really starting to look at this in that light. And that's really what needs to be done here.
And I thank you so much. And I know that all of us realize this is not just, a problem in the large metropolitan areas and cities. Here in Peterborough, deaths occur constantly, and unfortunately that gets pushed aside and minimized. But I thank you for bringing again to the forefront the humanity pieces that we all are a part of. And we hear a lot about, dignity at the end of life. And that that phrase gets interpreted by many people many different ways. I am grateful today to hear that and you've used that term around that. That's the human piece that we all deserve. And whether that's homeless, that doesn't change anything. The right to have an ending of life that conveys dignity and care and compassion is such a necessary piece. And yet it's sad that it's such an uphill battle, and that's the frustration.
For sure. Yeah, thank you so much for that. And thank you to you three for this opportunity. I so really appreciate it. And I think just creating platforms for discussions like this is so important, and making space for a topic like this on an ongoing basis says a lot about you and your team. So thank you so much for having me.
Thank you so much.
Yeah.
As a way of closing, we often ask our guests just to share, is there anything you want to say about that we haven't covered, or even just like, how has this work changed you?
Yeah, I know this may sound at odds with some of the things I've said in this interview, but it's actually made me more hopeful. Working in these spaces, as we've talked about, can be very dark and gloomy at times. But the fact that we have teams now across Canada that dedicate their day-to-day to care for people who experience health disparities, the fact that we have mainstream healthcare institutions and palliative care institutions thinking about, well, how do we do equity? How do we do equity better? The fact that we're having this conversation on a podcast and show like this, it to me, that speaks to hope. I mean, we've seen also in multiple reports at the provincial and national level now, discussions about health equity and the importance in our palliative care strategies. We're seeing politicians even talking about this. I just thinking about the last 9 years of my practice, like how much that has changed. I can't imagine how that might be viewed by people who've been around doing this work longer, right? And so I've been more and more hopeful each and every day that we are coming to the realization that this is necessary work, and that to do this necessary work, we have to put resources and efforts behind it. And now we're actually seeing those efforts, and that makes me really excited about what's possible for the future. And so I guess I'm ending this conversation on a note of hopefulness that I hope will continue to increase over time.
It's a beautiful. I think a note of hope feels like a beautiful note to end on.
Thank you.
Yeah.
I'm going to end on something else. I just think for our listeners, I love the fact that you're wearing a shirt that says "Disrupt the Status Quo," and the status quo is, let's put humanity, let's put dignity, and let's put equity back into the equation. And I ring on side your hope, because those should be things we should be able to reinstill back into our systems. Right.
For sure. Absolutely.
And so sorry, Julie, I couldn't get off of here without commenting, because listeners won't necessarily see the t-shirt.
All right.
Great.
Thanks again. Thank you so much.
All right.
Thanks so much.
Thanks for listening to What Now? On the Threshold of Life, Death, and Grief. What Now is produced in partnership with Hospice Peterborough. Music by Paradise Garage. Technical support provided by Sean and Jonah Heikert. What Now is recorded at Thin Spaces Studio. You can find more episodes of What Now for free on most major podcast platforms, including Spotify, Castbox, Apple Podcasts, and Overcast. If you want to support us, please follow and leave a review wherever you get your podcasts. And tell your friends. It does make a difference.